Okay, I'd like to introduce the next presentation. The title is Understanding Neuropsychiatric and Neurological Complexities in Lyme Disease and Co-Infections, Insight from Case Studies by Dr. Aylin Ozdemir. And her background, she's a pediatric in background with integrative and functional medicine training as well, and trained originally and she's currently medical director of pediatric associates in Jacksonville, Florida. She completed her training in University of Istanbul, did postgrad training in Queen Mary's Hospital in Children in the UK, and then underwent pediatric residency in Children's Hospital in Philadelphia and Long Island College University Hospital, SUNY State University, New York. And she's been involved in a number of different areas of functional and integrated medicine, doing further training in the University of Arizona under the direction of Dr. Andrew Weil, who used to be Dean of the Medical School in Michigan State University, where I trained of interest. And she did further training in integrative and holistic medicine at Scripps Center in California. So she's had a wide range of experience, and she'll be sharing her experience today. Thank you for coming.
And thank you so much for having me here in beautiful Finland and giving me opportunity to present my last 26 years here. And I have no conflict of interest to disclose, and I want to share that first. And the learning objectives of this presentation is pretty much analyzing neurological sequelae of Lyme disease, including cognitive, psychiatric, and sensory-motor impairments and diagnostic challenges. And I also examined evidence and linking Lyme disease to autoimmune responses and neuropsychiatric and neurologic disease complexes. And we also explored in developmental impacts in pediatric patients, particularly in cognitive and behavioral domains such as autism, PANS, PANDAS, and infections, plural, infections, never one, induced encephalopathies. And introduction, pretty much we all know by the second day here, and Lyme disease caused by Borrelia burgdorferi and transmitted via zoonotic ticks and as a complex multi-stage infectious disease. While early treatment can lead to full recovery, delayed and inadequate treatment may result in persistent symptoms affecting multiple organ systems. Increasing evidence points to neurological complications, what we call neuroborreliosis, but we also saw a lot of autoimmune presentations in our patient cohort and developmental disruptions, particularly in children. And then my background is pediatrics, so some of my cases pediatrics, but we have had quite a few adult cases in this study too. And this presentation highlights the limitations of standard diagnostic methods and potential benefits of specialized testing and the need for an effective paradigm for Lyme disease management. So methods that we use in extensive literature review and PubMed and different medical literature available to us. But inclusion criteria was human studies focused on neurological, autoimmune, and developmental delay children, or regressive autism, or in neuroatypical children, and who did not have any developmental problems before. So symptom profiles and diagnostic methods for seronegative Lyme disease and co-infections. So our patient cohort often were negative for every single test, and those are the patients I will be presenting here. And also positive IgM and IgG test indicating ongoing and previous infection. So that was quite challenging for our colleagues and treating, diagnosing, and trying to come up with a plan of care for Lyme or co-infections or infections-induced neuroinflammation patients. They just didn't have clear criteria to use for clinical correlation, and using the test result, for diagnosing or treatment purposes. But when I start talking about the cases, and I hope I'll be able to help you understand how to clinically correlate the lab results to the patient outcomes. And second part was serological testing after an antibiotic challenge, sometimes necessary because immune system is so burdened by the bacterial biofilms and infection load, and we may not be mounting antibody response. So that's why clinical suspicion and clinical correlation is the key in our patient cohort here. And outcomes and proposed mechanisms recorded, synthesized, and supplemental analysis were performed. And the case summaries for our patient care center, which is in Florida, and analyzed, and we submit to publication some of these cases. And my first case is actually isn't interesting for me because I was part of a list discussion, and then we were invited for a farewell for a friend who had pretty much end-stage disease and potential early glioblastoma or low-grade encephalitis. And I'm expecting within a year or two die from brain tumor. That was the outcome was given to him. So, and with this interaction, I was like thinking, I would have to ask if there was a tick bite. I couldn't help myself. So, and I said, you have diplopia and all these glioma, low-grade glioma. Have you had a tick bite? Yeah, 8 years ago, first time in my life. I said, you're in Istanbul. How did you find a tick? Oh, I was in Sweden. So and I said, did you have a rash? And he didn't have a rash, and he didn't remember. But then getting deeper in the history of this 55-year-old young man, he said, wait a minute, I have got migratory arthritis. I have anger outbursts, and I just don't even know where these emotional vibrations constantly come in. I don't even know where it came from. It's just, I don't feel like me. And then he was having daily headaches, nausea, vomitings, numbness, sensory loss, weakness on one side of his body. And in spite of significant arthritic symptoms, he never underwent Lyme disease or co-infection workup. So I asked him to go have a disease workup in Turkey. And then I also called a couple of friends, and there was no test really available. Surprised at my findings. Then we submitted his specimen to across state borders, country borders, to Finland. And then, and these were his findings. And then right-hand side one is spinal fluid findings, and it was all clear, no antibody response on ELISA test. But, and his, sorry. Okay, sorry, go back to the previous slide, yeah. And his IgG response for Lyme disease, Borrelia, and then persistent forms were indicating exposure. So then it's very important, I think, in our clinical understanding of exposure and disease. If we just start putting our focus into, okay, this is, how do I interpret immune memory of an IgG? And we have to look at the patient. Okay, so then based on a discussion and long treatment plans, and then we decided, why don't we just give you a trial of treatment and then collaborated with physicians in his location. And he received IV ceftriaxone to cover neuroborreliosis. After 3 years of diplopia, double vision, and in layman terms for it, and his double vision entirely cleared within the first week of treatment. So his headaches disappeared, and then his migratory joint pain disappeared. He was able to lose weight. He said, I can actually walk without getting tired. So these kind of clinical correlation with the IgG could be potentially interpreted as an immune memory. Is, to me, look at the patient and outcome. And I think we had a good response here. Down the road, he also had a mycotoxin exposure and heavy metal exposure. Currently, he is being supported for those environmental challenges, and he's quite stable now. And my second case is, this is adolescent came from Miami to my clinic and with severe debilitating headaches, and she pretty much was confined to her dark room for 2 years. 13 years old female, post-pubertal, and everybody's thinking, okay, puberty hit, she's depressed, anxious, and she's socially avoiding. Her twin sister's prettier than her, she doesn't want to socialize. And so then they were quite blaming for this young lady, and she was getting more and more depressed and didn't want to see anybody. And so then $1 million workup at Jackson Memorial in Miami. MRI revealed small area of low-grade inflammation in the left parietal region, no clinical neurological symptoms except headache. So, debilitating headache. And then they said this could be parasite, maybe came from eating pork. By the way, she doesn't eat pork. She's Jewish. And after anti-parasitic treatment they gave her, and then her headaches did not improve. And then, so she came to our clinic, and they were quite frustrated. She had a huge bar mitzvah to go to, and then she couldn't get out of her room. They were devastated. So, and I asked for spinal fluid investigation, and they provide me results from Miami Children's Hospital. It was normal. And then all the commercial labs available to us in the United States, including the reference labs, that we send typical patients to specialty labs for Lyme disease and co-infections, were also negative. So I said, okay, we have to send a specimen across the pond to Finland. So that's what we did. We sent a specimen to Finland, and that was showing, again, exposure to Lyme disease. And this is her results. And again, and a weak response in IgG, but again, indicating exposure in our belief system, and that's our outcomes, and confirm the patient's diagnosis. So she received IV antibiotics, again, IV ceftriaxone protocol for 3 months. We also put her on IV nutritional therapy protocol, which I use for neuro recovery patients, and using whole systems approach. And we start from gut, neurology, psychology support. And she stayed with us for 90 days. And then MRI lesion cleared, her headaches fully cleared. She had an amazing bar mitzvah. And then this was the case, is just really, if there's a neurologic implication, all the labs are negative, Lyme disease should be considered in the differential diagnosis. And this is a patient came from Michigan to see us. But interesting thing is, I just want to mention, our clinic is not a Lyme referral center. I have a general pediatrics clinic, and with 3 offices, and I also have a multidisciplinary complex integrated medical center. So usually we get referrals from all over for diagnosis unknown. So we do not really market ourselves, or we don't want to put ourselves out there as Lyme clinics. The reason for that is regular Johnny may have Lyme disease unless really you know how to pick up that person in their natural environment. They may not even smart enough to go to a Lyme referral center, and that's how they get it. So this patient was actually just like that. Very resourceful family, super smart parents. And then she was suffering from age 8 through until we saw her 21 years of age. Her diagnosis was restrictive pattern of anorexia. So extremely restrictive diet and then fatigue, and she would be a good fit for ME diagnosis, myalgic encephalitis, and which is chronic fatigue syndrome with the old name in terminology. And then she was having severe anxiety related to food mainly. And then, but then one other thing that when she came in our clinic, I was like, why is she not walking? I understand she's anorexic. Why is she not walking? I'm like, what is going on here? So then she came from Michigan. In my book, Michigan is hyperendemic area for Lyme disease and co-infections. So, and then we asked extensive history of bite. She could not remember anything, but she's a big time cross-country runner. She said I was around the bushes up until I couldn't walk. I can't even forget about running. I was part of the track team at University of Michigan. So then all of a sudden, a long history of maintaining, but all of a sudden she took a nosedive. Then the year she came to us right after COVID emerged, it was like, okay, so then COVID might have stirred some things up here. She was probably one of the highest SARS IgG spike protein antibodies in our patient cohort. So she had 25,000 spike protein titration. So we said, COVID must have triggered something. What is the stealth infections actually causing her not able to walk? So, and then we again send a specimen, and then I will share the results in here. And these were her results, pretty high COVID antibody titers. And then this was her results from tested labs and a lot of reactivity. Again, clinical correlation, but we chose the integrated route for her, which means conventional and holistic whole systems approach together. So because of her severe chronic inflammatory demyelinating polyneuropathy confirmed by muscle biopsy, we chose to give her immunomodulator dose of IVIG. So like she would, right after high dose of IVIG, she would walk, have a great energy, and last for 3 weeks or so. By the end of the 3rd week, she would need another infusion. So then we combine that therapy, of course, with the targeted antibiotic approach, and which provided her full recovery of symptoms after 10 to 12 years of anorexia, nausea, and chronic fatigue syndrome. And then currently she's a nursing student and she hopes to join my practice. So cells. And this is actually a case, could have been multiple cases in one case, in 22-year-old female and with global developmental delay, but symptoms starting around 3 months of age with recurrent lung infections and wheezing and progress further in severe feeding difficulties, acid reflux, and severe food allergies and anaphylaxis, and then unable to talk, unable to walk, severe auditory processing deficit, and then diagnosed 26 months of age with CVID, common variable immune deficiency, at Duke Medical Center. At that point, she was given immunomodulator dose of IVIG since she did not respond immune deficiency dose of IVIG. So in the caveat of this whole history, and then she also underwent a Lyme disease and co-infections workup, and 10 years late. And then 10 years of age diagnosed with Lyme disease and multiple co-infections. And after treatment of those infections, and her cycling fevers every 4 to 6 weeks subsided, recurrent fever subsided, and a neurotypical behavior started emerging to be a more neurotypical. And so from atypical to neurotypical behavior. And the cyclic neutropenia disappeared, limping, difficulty walking disappeared, and became more neurotypical. So then this patient, after 17 years of IVIG infusion, and after membrane recovery protocol, which I use a lot of phospholipid in my practice, it was an intense 6 weeks phospholipid protocol. She was deemed not to have IVIG anymore for CVID, common variable immune deficiency. And it was year 2019, after 17 years of high dose of IVIG. And what happened 2020? COVID happened. So we were like, fingers crossed, what is going to happen with COVID? After intravenous immunoglobulin stopped after 17 years. 2021, January, COVID contracted, 3 to 5 days runny nose, no other symptoms. In the past, same patient would be ICU admitted and almost intubated, restricted lung disease and lung flare-up due to babesia would not be treated any other way but complex antibiotics. So after this membrane recovery protocol, she was able to stop IVIG and function normally. But then second bout of COVID and create a huge immune burden for this patient. And these are her results. all clear, and Eliza tested, however, and then we said something is not right, and she's symptomatic. Her direct testing is positive. So then we also know that when patient is actually burdened by multiple infections, and the COVID spike protein is a huge burden, another 20,000 spike protein IgG burden patient here. There's a second winner of the spike protein load, and reactivated stealth infections, all of them in the direct testing in the background. So it's very important picking the right test for the right time, for the right patient. We're not just gonna go after antibody response. Maybe we have to go T-cell response, ELISpot, and in different testing, but sicker the patients, more direct testing that we use in my practice. And this patient treated, fully recovered, and is doing really well. So then one other thing is doing well in Lyme patient cases. For us, we're looking clinical correlation, not the immune response necessarily for diagnosing treatment for these patients. Not only that, gain of function. That's my success point for the patient. Are you living? Are you thriving? If the patient say, I'm thriving, I'm doing everything. I mean, good, I'd like to see you once a year. I don't want to see you more than that. I'm happy. So gain of function is something very important. So this is another interesting case. 25-year-old male came to me in a wheelchair, and then he was told by a tertiary care center that he will be in a wheelchair rest of his life. And I tried to examine him. The minute I put my hand on him, he screamed and yelled. He was in so much pain, and he had multiple and long axonal demyelinating polyneuropathy diagnosed by muscle biopsy. And no one at the tertiary care center done any stealth infection workup for him, even though he had significant neuropathy. Like for neuropathy, I'm just thinking, Bartonella, why not? They didn't do that. So then we asked, and can we get all his records so we're not reinventing the wheel? We sent his labs to our reference labs that we use for stealth infection workup, and we just didn't have much luck for those. And then we end up sending again the specimen across the pond. And then this is his lab results. And then he had Babesia and Lyme and persistent forms as an exposure, the signs of exposure. We clinically correlate that to a patient. We just discuss with the patients pros and cons and alternatives in America, because that's the country we practice medicine in. And the patient has to choose. You have signs of exposure, you are in debilitating pain. I can give you antibiotics that might help you, may not help you, but it doesn't hurt. If it hurts, you will stop. So then we gave him actually PK protocol, phosphatidylcholine, and an IV nutritional therapy. And our goal was to mainly support his detox pathways and allow his whole systems to rebuild itself. He had incredibly favorable response within 3 months of intense IV nutritional therapy and then cell membrane recovery protocols. His pain was 50%, I would say, anecdotally, within the first 3 months. And then after diagnosed infection, combining antibiotic treatment and also treating him for spike protein burden. And we use similar protocols, and it's been shared in this conference earlier, how we support SARS burden. And I use a lot of NAC/IV in my clinic, and that really provided so much relief for this patient. Not to mention NAC is also incredible liver detox. Somebody abused alcohol consistently for over a year at the toxic levels that cause him demyelinating polyneuropathy, and only aggravated by the stealth infections in the background and alcohol, like almost like putting salt on a wound kind of thing. So then, and he is currently, it's a good, from wheelchair bound, and he is actually a CrossFit person at the moment, incredibly successful. And then he is doing very, very, very well and working in his family company as in a construction company. So he's just fully recovered. And our next patient is, this is patient specifically for late onset neurocognitive decline or regressive neuroatypical behavior with the anxiety and depression. So then gradual onset. And the family lived in a hyperendemic area. They're from New York, and they came to our clinic, and with academic struggles, anxiety, fatigue, brain fog, and then she just couldn't remember simple things. And before, she was kind of a life of the party, and we were trying to figure out what happened to her, in high school. And mom was thinking, she's shy, could that be social stress, peer pressure, just all kinds of things. So we offered to treat her, test her first, and then this was her test result, showed the persistent forms, that we still offered her treatment, full-blown combination of cell membrane recovery and IV antibiotics along IV nutritional therapy. And then she was able to finish high school, and she's in college now, and she fully recovered. This patient also, symptoms were aggravated with the COVID exposure. And this is not a gradual regression, but this is a sudden onset of regressive 8-year-old male, came with the anxiety, depression, school refusal, kind of overnight. It, of course, diagnosed with PANS pandas, and then we treated him successfully with the immunomodulator dose of IVIG, and he fully recovered from PANS pandas, and he had history of strep. All of a sudden, he started developing POTS after we fully helped him. So what is going on here? So while all is going on, and then he moved to a new home, and I just like, okay, we are in Florida. Tell me more about your house. It was a basement in front of the ocean, very damp place. And I said, why don't we test him for mold? Because we successfully treated these infections. He was doing really well. And then what happened all of a sudden? And then he was positive for mold exposure, very high ochratoxins. But the one thing about this case, an 8-year-old, is very unusual for pediatric population to show POTS signs and symptoms before teenager years. So then when he present these symptoms around 8 years of age, it must be a culprit. So this case actually helped us learn, and there's something happening with the brain permeability and mycotoxins. So then we treated him with aggressive mineral therapy, IV mineral therapy, and he fully recovered from his POTS within 3 months, and dizziness went away. And then we were able to also test and treat him again for reactivation of the infections that we interpret this as after mycotoxin exposure. A patient who fully recovered, done really well with PANS and pandas after mycotoxin exposure, he had flare-up of his symptoms. So we treated him with IV nutritional therapy, cell membrane recovery, and he didn't have to go back on immunomodulator dose of IVIG. And however, he received PK protocol, phosphatidylcholine protocol, to help him recover from mycotoxins, not to mention a lot of binders, push and pull protocols to constantly clean his gut and help him detox and eliminate with binders. And he did really well. He's in college now. Yes, and this was his mycotoxin levels. Yes. Sure. We retested our, so. Was that a tested as well? Yes. No. This was different criteria we did. We wanted to just, since we were going to treat him medically, it wasn't just our research case, we had done this test also. Yes. Good pick. So this is a very complex mast cell activation syndrome case, 23-year-old female, after COVID exposure, and also received the COVID vaccine, came with incredible mast cell activation syndrome. She would even react to normal saline infusions. Like she would have hives and then feeling like throat closing up from normal saline infusions. It was very, very complex patient. And then she was there for hives. She didn't know anything about Lyme disease and co-infections, never heard of it. even though her family was from New York, they denied Lyme disease for themselves. So then, okay, I said, the part of the mast cell activation syndrome, I need to see what is going on in the background with your immune system. We have to test everything. So then she said, we have insurance. We went to Mayo Clinic. All Mayo labs were normal. We send more tests to commercial labs. They were all normal. I said, can I please send specialty labs to specialty labs, reference labs? And in the end, and they're convincible to send them. And she also had positive for mast cell activation syndrome with high prostaglandins and the histamine. So she was confirmed case of mast cell activation syndrome, rather than the patients often we get, they think they have mast cell activation syndrome. This was lab confirmed case. So then this patient's lab results from tested indicating an old infection with mononucleosis, high spike protein burden, and exposure to Lyme disease and Borrelia persistent forms. So we stabilize her mast cell activation syndrome with the protocols that I follow in my clinic, including quercetin infusion. I use a lot of quercetin and NAC for these patients. They do really well. And she did tolerate IV botanicals, but did not tolerate any antibiotics. So then we treated her botanically and supported orally. And we also use a spike protein reducing protocols in our clinic. She did very, very well, and she's stable. And what she had in the background, COVID just pushed it over. And that was the case to learn from. And one thing about this patient is every single time we draw blood to do testing for her, I spin blood and I inspect them. So since 2021 or so, it took me a year to wake up to that. And this was the worst in her case. This was her fibrin tissue. We end up sending this to clot in her serum, New York Blood Bank, and the pathologist said, this is probably an immune complex, happened as a clot. But interesting finding about this patient, even though she had come to us with severe hives, and then she, after COVID vaccine, she started having slurred speech and started slightly dragging her feet and spontaneously recovered. So if she had a little TIA with one of those clots, and then nobody diagnosed her. So, but there are a lot of patients probably walking on the streets, having soft neurological findings, and then they're not coming to surface. But then this was pretty impressive. I just want to share with you. And this was a blood clot in her serum after we spent mast cell activation syndrome patient. And this was her test results. Next patient is 16-year-old female with psoriasis, and she actually was a sibling of another patient we treated. The mom said, why don't you look at my other child? And I said, I don't treat rheumatologic conditions. I treat the root cause. And then as part of that root cause workup requires Lyme disease and co-infections workup, since she has a disease causing rash. So she was positive for Lyme disease. They're from New York, and I treated her. But then they remembered later on, oh, she's got joint pain too, but she was diagnosed with seronegative arthritis. And then every single seronegative arthritis should have infections workup, not just one, plural. And then her anxiety and headaches also resolved after she got treated for these. Lyme disease and persister forms, exposure. And our next patient is 44-year-old male and came to me quite suicidal. They told me, my wife sent me here and I'm about to kill myself, because he had such a terrible trigeminal pain and trigeminal neuralgia. And then he had also peripheral neuropathies and extreme pain. So I said, I am not a pain expert, but I can do some workup. So, but when I got the work history from him, and he worked in a facility that could potentially be having a lot of mold exposure. So we test him for mold, but he is actually a winner of the tested labs, and he was a very sick patient. He had a lot of things flared up. He had a lot of burden. He grew up in Nebraska, and multiple tick bite. He kind of rolled in ticks pretty much growing up. He was never diagnosed. And after mold exposure, which he was exposed occupationally at work, and things built up over that seven-year period. And after our diagnosing and treatment successfully, and he recovered from pain syndrome, he quit his job. He's quite happy, moved back to Nebraska and living on a farm, and we gave him a lot of Arctic repellents. Okay, and this is his mold test results and very high ochratoxin. And he also has different strains of molds, and his used to be a real-time labs, now US Biotech labs, and we do mold testing through them. And so discussion, our case series illustrates the complexity and variability and challenges in diagnosing and treating conditions such as Lyme disease and co-infections and related neurological psychiatric disorders. The cases ranging from acute peripheral neuropathy exacerbated by stealth infections to acute infections induced encephalopathy. Infections, I always say plural, never one thing. And PANS and PANDAS underscore the multifaceted nature of these illnesses and highlight several key themes and lessons learned, included but not limited to the lack of diagnostic testing and criteria. And clinical relevance in here. And I mean, two-tier testing approach is falling short. We need better testing. Multifactorial environmental impacts on the immune system creates a spectrum of Lyme disease and co-infection presentations, and not one single patient identical to other one. So the true evidence in evidence-based medicine is the patients themselves. Please listen to the patient, look at the patient. So then we also see mitochondrial dysfunction with multiple infections, mRNA vaccine impact that we are seeing, and also spike protein burdens, and making our diagnosis and treatment of these diseases even more complex than it was. So then, very important to also recognize biofilm disruption using botanicals alongside IV and oral nutritional therapies, environmental detoxifications, SARS-CoV and mycotoxin elimination, mitochondrial support has been showing significant benefit for my patients. And in conclusion, the presentation serves as a vital reminder of the intricate and often overlapping nature of the Lyme disease, co-infections, and related neurological and psychiatric disorders. It emphasizes the need for comprehensive diagnostic approach. And we already mentioned all the other intricate diseases and environmental factors. I always call it trauma, toxins, and thoughts. And then we always have to consider patient's environment and therapy resistance sometimes. Do not forget to ask patient therapy resistant and then get into deep in their psyche. Furthermore, it underscores the need for continuous research, innovation in diagnostic methods and treatment protocols to better understand and manage these complex conditions. And then true evidence is the patient. And then we need a doctor like that. Dr. Charles Ray Jones, my mentor, and listen to the patient without judging. Without Dr. Jones and his belief in the patients and listening without judgment, and some of us would not be here today, have the courage and stand strong. Because if we had a provider, gaslit, didn't believe what we're saying or sharing as a parent or as a patient, and then doesn't believe in the patient, then patients lose hope and we couldn't stand. And this is my research reviews, and this is my contact. Thank you.
Thank you, that was really awesome. In your 22-year-old patient with PANS that was positive for Lyme disease, Bartonellosis, and babesiosis, how did you detect active infection for Bartonella?
And it's a fish test. It's a fish test. Yeah, it was a fish test. Yes.
In that same patient, you mentioned APD syndrome.
Sorry, auditory processing deficit. Auditory processing deficit. And then it's part of the neurologic symptoms. They're quite sensitive to, especially their parents chewing or noise, these patients, pediatric patients. Very interesting. And they're hyperacusis and auditory processing deficits. They're hearing, but they're quite not decoding the language they heard.